Let's talk about facility growth and the start of institutional care. Again, back in 1974, when compliance measures were implemented for facility staffing, for fire safety, for delivery of care, and when Medicare and Medicaid were both well established, corporate owners decided to take advantage of the opportunity by purchasing different nursing home facilities. Corporate chains were established, and there was the purchase. Owners decided to purchase different nursing homes and to have them under their umbrella for delivery of care. That umbrella was for the oversight of both care and operations. So the goal was to not only make sure residents were receiving optimal care, but also that the company and the facility and the individual facilities were indeed becoming financially profitable, that they were indeed making money. So that establishment allowed for nursing home administrators to seek different opportunities, to be selective in the types of facilities they chose to work in. Corporate owners were then purchasing more facilities, and so it became a cycle where there were a lot of opportunities for care to be delivered and for individual administrators to seek where they would work as long-term care administrators. So the growth became explosive as of the mid to late 70s. There were policy waivers that were established. Again, there was kind of a struggle between keeping residents at home in the community, but also having long-term care facilities available in the community for service offerings. Medicaid had initially authorized institutional care only, but then later bridged to offering financial support to community-based services under the Medicaid umbrella as well. Then there was deregulation. There were rumors upon rumors that standards were being relaxed, and some opposition groups were fighting to keep control of long-term care facilities in place, while others were still on a mission to keep residents at home in the community-based services program. And then in 1987, things became explosive with the growth of OBRA 1987. That stands for Omnibus Budget Reconciliation Act of 1987. It increasingly and significantly improve the quality of care in long-term care facilities. So 1986, 1987, that was a huge turning point. Make sure you remember that. Huge turning point in our profession. OBRA 1987 emphasized both quality of care and quality of life, establishing rights for our nursing home residents. We didn't want them to be admitted into facilities just for the sake of their care, but we also wanted to make sure that we were being respectful of their individual rights. And the OBRA Act of 1987 was the start of that time frame when we began to notice that, or we began to implement more care for individual residents and that they had rights rather than just admitting them all together in a cookie cutter care approach. We didn't want that. We wanted to make sure we were treating them as individual residents with dignity and with respect. Policies to regulate other services. Assisted living became fast growing in the late 1970s, early 1980s, and most states had enacted some type of regulatory oversight, along with adult daycare became another option. Then there was the Balanced Budgeting Act of 1997 requiring home health agencies to be regulated and reimbursed, also under the PPS umbrella. I encourage you to review Table 2.1, which shows Medicaid expenditures over the years and how much care was expensed in long-term care facilities for caring for our residents. Current state of long-term care policy from a financing perspective, again, there's been this push and pull, this tug of war between Medicare and Medicaid for the best type of financial model. So in long-term care facilities, Medicare is a very short-term program. It's usually less than 90 days, requiring people to be treated on the Medicare wing, and it's very short-term. They have to meet their goals. Hopefully, after the goals are met, they may be able to return back home to their prior level of functioning. If not, they would then transfer to the Medicaid side of the facility. If one is utilizing their Medicaid benefits, it requires residents to have exhausted all of their financial savings. Pretty much you are considered poor to be able to apply for Medicaid services. There's that shift again from nursing home to community-based care, which one is most appropriate. There were waivers that allowed for some persons to stay in the community while others opted for their benefits to live in a long-term care facility if they needed 24-hour care. Government has been concerned about rising expenditures, and that's why there are different types of prospective-based PPS, prospective payment systems, that have been developed over the years to ensure that facilities are not spending more money than they should for the delivery and care of each resident. Few options are available to cut costs, which make it even more difficult to establish quality of care, but the opportunities do exist. From a historical and financial perspective, very few people have private insurance for long-term care services, although it's always been made available. Very, very, very few people have access to private insurance. There are many organizations that do allow people to purchase private insurance. It's marketed to individuals through a variety of corporate owners, through managed care organizations, or just different types of financial corporations and small companies. Private insurance does allow for Medicaid benefits to be used once the benefits are exhausted. So if someone purchases a private insurance, they're able to use it throughout their service as needed in a long-term care facility. Once those benefits are exhausted, a resident would then automatically be eligible for Medicaid services. Persons can at least maintain some, if not all, of their financial assets when they're applying for Medicaid if they have private insurance. There's also an Affordable Care Act called Community Living Assistance Services and Supports, called CLASS Act. It was made as a part of the Affordable Care Act, but it was later dropped. So that is no longer an option, but it's just good for you to know about because it is part of the long-term care financial aspect of our history.
The thing about it is,
Policies for the future. Be advised that for older adults, the Institute of Medicine projected in 2007 that the number of older adults with impairments would increase from 14 million in 2007. It's projected to increase to 28 million in 2030. And because of this, there will always be a need for long-term care services. Even though beds and utilization may decrease, we will always have need for caring for our older and frail elderly throughout our communities. There's demographic information that also includes growth of the elderly population while the working population continues to change on many different levels. We have the financial burden of long-term care. From a financial perspective, we have the labor force crisis, shortage of workers. Our CNAs and other employees like laundry, dietary, and housekeeping, they generally struggle for competition. We struggle as a profession with competing for those types of employees that we need on a daily basis. We also have health and disability trends that are critical within our service population as well. So then we have new policies. We have policies for prevention, physical activity, safety, crime prevention, fall prevention. There are a lot of different programs within the Affordable Care Act that take necessary steps to help focus on prevention for those who need long-term care services. There are financing policies that are available to help meet long-term care expenses, but we still do not have a comprehensive long-term care program that helps to meet the financial needs most families encounter. At long-term care services, the financing can become a burden for many families if they are unable to apply for Medicaid. We still have workforce problems, again, with skill development, training specifically in geriatrics, standards for nursing home administrators. There are a lot of challenges to work toward improving the need for workforce. We need a strong workforce. We need strong administrators like yourself, so we applaud you for taking the time to train and do all that you can to learn and how to prepare for your upcoming exams. So the workforce that we are struggling with is across all lines of our facility staff. From an HIT perspective, health information technology, we're still working to be able to interface long-term care with other healthcare components. We do not have the connectivity yet that we desire, so that when an elderly person is at their doctor's office, or if they've had treatment from different entities within the healthcare spectrum, we want to be able to connect their medical records so that we're all able to interface and to be able to read those medical records so that we can make sure the patient is being treated properly. We want to make sure moving forward that there are mental health services available, outcomes, appropriate measures, appropriate care, and financing, of course, of mental health services is going to be important in the future as well. We continue to work on evidence-based practices throughout our long-term care spectrum to make sure that for all care that is delivered, from infection control to the therapies, to the mental health needs, to the physical health needs, that we are working on evidence-based practices and new innovations in care delivery. There's always a lot of new and exciting things that are being developed, and we hope those new and exciting programs will then be connected toward regulatory practices as well.